Ma'am, good afternoon. Good afternoon, everyone. COE STM Kolkata welcomes all the participants for today's RDLS session. Today's topic is management of hepatitis B and C among PLHIV, and the speaker is Dr. Dolanchampa Modak. Dr. Dolanchampa Modak, ma'am, is the Assistant Professor of Tropical Medicine and the Deputy Program Director with the Center of Excellence in HIV Care at the School of Tropical Medicine, Kolkata. She is also a master trainer for NACO and a faculty of PG Diploma in HIV Medicine course for IGNO. She has several publications in national and international journals. We welcome you, ma'am, for today's session and request you to start the session.
Thank you, Shita. So let us begin the today's topic, that is the management of hepatitis B and C infection among PLHIV. Ismail, Is- Ismail, please come.
Ma'am, click anywhere on the slide and then next. Yeah.
So yes, it has solved. So in today's session, we learn and we all knows that we will discuss about the global and simultaneously the national burden of HIV and both hepatitis B and C, and about their epidemiology, natural history and progression of all these three infection. And simultaneously we will learn how to evaluate the co-infection, and then how to treat the co-infections and how we can prevent this co-infection, that is hepatitis B and C ingestion among the PLHIV. So all of us know that total HIV burden is around 39 million in the world, and people acquiring HIV every year, that is annual acquisition of HIV is around 1.3 million. And people and it is around PLHIV which have who have co-infection around 6.3 million. So adult, that is above 15 years of age, around the 37 million people are living with HIV/AIDS, and men is around 17.4 million to women. I think it should be altered. That is men around 20 million and women around 17.4 million are present throughout the world. And among this male population, people acquiring HIV 5.4 lakhs every year. Among female population, it is among female population it is 5.4 lakh, and among male population it is 6.4 lakhs annually. In children less than 15 years of age, in the globally 1.5 million children are having HIV infection. So HIV, about the HIV epidemic, the new statistic 2022, that is the adult of 15 to 49 years of age, HIV prevalence is around 0.2%. 0.2%, and among male it is 0.22%, female it is around 0.19%. People living with HIV, it is around 24.67 lakhs, and among this 24.67 lakhs, 23.9 lakhs people having harboring HIV, men, and 10.86 lakhs are women. By WHO definition, Southeast Asian region, in 2022, it is around Southeast Asian region, it is around 61.4 million people are living with HIV, hepatitis B co-infection, and 70,000, I think. It is not visible. around hepatitis C, 50 million people having hepatitis C infection, and এটা সরিয়ে দাও। So globally, hepatitis B infection is present among 254 million people and hepatitis C around 50 million people. In Southeast Asian region, hepatitis B is present among 61.4 million people and hepatitis C present among 9.1 million people. So comparing the global situation with the India, new infections of hepatitis B is around 1.2 million have new infection annually and 1 million hepatitis C infection occur annually. Chronic infection, hepatitis C infection actually is the more commonest chronic liver disease around the world. Cause of chronic liver disease around the world, hepatitis C virus infection is the commonest cause, but its number is around 50 million of hepatitis C and 254 million of hepatitis B infection present globally. In India, 29 million people having hepatitis B, 5.5 million people having hepatitis C infection. Chronic hepatitis B and C infection causes 1.3 million deaths each year due to liver disease and cancer. What cancer? Na hepatocellular carcinoma. And in India, it is around 1.23 lakhs death occur due to viral hepatitis. Among them, 2.4% of hepatitis B and 28% of hepatitis C cases are diagnosed. So, hepatitis B seroprevalence, national hepatitis B seroprevalence is around 0.95%, highest in group A people, A state that is Telangana, and group 12 that is Sikkim, Arunachal Pradesh, Assam, Meghalaya, and Tripura. And group 7 that is it is around 1.6%, it is Mizoram, Manipur, and Nagaland. Seroprevalence was higher among men 1.16% than women 0.75%. Among hepatitis C, seroprevalence is around 0.32%. Group 7 state, that is Mizoram, Manipur, and Nagaland, has the highest seroprevalence of hepatitis C, that is around 1.68%, followed by group 9, that is Haryana, Punjab, Chandigarh, and Delhi. It is around 0.56%. And group 1, that is Andhra Pradesh and Telangana, it is around 0.44%. And it is also the seroprevalence is higher among men compared to women. This is the graphical presentation. We can see the seroprevalence of both their diseases, hepatitis B and C, in different part of India. So hepatitis B and C co-infection of with HIV. All infection acquire through the same route. That is, common route of transmission of all these diseases are vertical transmission, blood and its product transfusion, and also injection drug use. So, and hepatitis C is more common among people who inject drug. Another portion is men who have sex with men and also have other risk factor common with HIV. Globally, hepatitis C in co-infection among PLHIV is around 6.2%, but hepatitis B infection is around 7.6%. Viral hepatitis is increasing cause of morbidity and mortality among PLHIV, and a comprehensive approach include what are the comprehensive approach include prevention, how we can prevent the acquisition of infection of hepatitis B and C among PLHIV, and the testing and early diagnosis, and then followed by treatment. And those who require vaccination, we will consider also vaccination to prevent the hepatitis B acquisition among HIV people. So firstly, we will discuss the hepatitis B and HIV co-infection. Why? Why it is important? Because the people who have HIV and comorbidity with a hepatitis B infection have more chance of chronicity of hepatitis B infection following an acute infection. So the chance of chronicity is around 20 to 40%. There it is seen in different studies that in a HIV patient, hepatitis B viral load is increased, and anti-hepatitis B E antigen, that is the replication occur more rapidly, and anti-replication antibody, that is anti-HBE antibody level is very low among the comorbid patient, co-infected patient with hepatitis B and HIV, and there is less chance of seroconversion of hepatitis B surface antigen to antibody to surface antigen in spite of relatively low level of transaminase, that is AST and both ALT. There is rapid progression to cirrhosis and hepatic decompensation, and simultaneously there is more chance of development of hepatocellular carcinoma and liver related mortality among this co-infected patient. There is high rate of reactivation and increased rate of occult hepatitis B. That is occult hepatitis B. How can you diagnose this? That is isolated hepatitis C core antibody positivity with hepatitis B surface antigen negativity and very low level of the detectable hepatitis B DNA. So there is higher chance of reactivation and increased rate of occult infection among these co-infected patients. And these co-infected patients, there is also more chance of flare of hepatic transaminitis, either due to iris or due to hepatitis B treatment interruption or drug toxicity or development of the resistance to these both either or both HIV and hepatitis B infection. So how will you evaluate? First of all, whenever a patient comes to you, you should take the history, that is the whether there is any chance of high risk behavior, any chance of previous blood transfusion, IDU, men sex with men. All this history should be taken and then followed by examination of the patient, that is clinical evaluation of the patient, history and clinical evaluation. So in during clinical evaluation of the patient, what are the findings you will search for? In hepatitis B patient, there may be jaundice present or not. And there, if the patient give the history of alcoholism, there are chances of presence of parotid swelling, Dupuytren's contracture due to estrogenic preponderance. There may be development of the gynecomastia, loss of pubic hair, loss of axillary hair, and there may be testicular atrophy in the male. And simultaneously, the signs of cirrhosis may be present, cirrhosis or decompensated liver failure. How we can address that? There may be spontaneous bleeding, history of spontaneous bleeding. On examination, there may be spider nibs and spammer erythema, or there may be scratch mark, clubbing. All this can be present during general examination and general survey. During systemic examination, you can get hepatomegaly. Sometimes you may not get palpate the liver due to shrinkage of the liver, and if the liver gets cirrhosis. Sometimes, and if there is the development of the portal hypertension, you can palpate the spleen. Sometimes there may be huge splenomegaly. Sometimes there may be history of hematemesis. There may be history of melena. Very important history. You should not forget to take this history of hematemesis and melena. Sometimes there may be superficial venous collateral. Sometimes there may be history of parectal bleeding and caput medusae, hepatic bruit, venous harm, all can be present during clinical examination, history taking. You should always remember and for search for these findings. Then if you think of hepatitis B co-infection, or if you have evidence that is surface antigen positive, then what to do? routine laboratory test, complete hemogram and LFT, that is liver function test, along with prothrombin time. Prothrombin time is one of the unique non-invasive prognostic marker of liver disease, and along with INR. It is very important. You should always recommend to do prothrombin time and INR in all chronic liver disease patient. And radiologically, you should ask for ultrasonography, and always search for alpha fetoprotein level, so that because this patient develop hepatocellular carcinoma more compared to the non-co-infected patient. And if there is signs of portal hypertension, do a upper GI endoscopy. And for serological investigation of hepatitis B, always do surface antigen, that is Australia antigen, hepatitis B surface antigen, along with to see the replicative activity of the virus. Always do hepatitis B E antigen and anti-HBe antibody, anti-HBC to C antibody. If you think that is there is chance there is acute hepatitis B, then always do anti-HBC IgM antibody. If you think it is a chronic infection, do the total anti-HBC, that is the core antibody. And the National Hepatitis Control Program always recommend it to do a hepatitis B DNA for all the patient or for evaluation of hepatitis B. And some things or some evaluation you can do at the bedside or at your OPD to estimate whether the patient develop chronic liver disease and the extent of fibrosis, extent of necroinflammation of the liver. You can judge. How? Now, liver biopsy is now is very rare. You better do the non-invasive test, bedside test or laboratory OPD test, that is the APRI score. It is done in the laboratory in the OPD basis, and the fifth score to assess the fibrosis of the liver. You can assess through fifth score, or you can do the metavit score. You can do the transient elastography and estimate do the fibroscan of the liver and estimate the fibrosis and extent of the necroinflammation. So without doing the liver biopsy is essential to rule out, to diagnose the hepatocellular carcinoma. Then you can also take the help of PET scan also. But for assessment of the cirrhosis of liver, the extent of the liver fibrosis and extent of the necroinflammation of the liver, you can do APRI score, that is aspartate platelet ratio index. In cirrhosis, that is low cutoff is 1 and high cutoff is 2. That means that if the APRI score is more than 2, you can stamp the patient is having cirrhosis. And significant fibrosis, that is 0.5 to 1.5. You can say that the patient has APRI score of 0.5 to 1.5, that is patient develop fibrosis. But beyond 2, patient is having the cirrhosis of liver. Fifth score, fifth 4, according to the fifth 4, if the patient develop F2, that is significant fibrosis is there. And transient elastography, if the patient's fibroscan score is less than 7, no fibrosis, in between 7 to 9, that is 8.9 in a kPa, then there is moderate fibrosis, and 11 to 14 severe fibrosis, and you can say that cirrhosis of liver is present. You should know the child score to evaluate the patient, that the patient and the extent of the liver injury. 2 clinical and the 3 or 4 laboratory parameters will help you to establish the liver disease and the assessment of the child park score to assess the chronicity of the liver disease. With this child park score, we can recommend the different type of drug levels, drugs we can administer in child park if the patient having child park score A or B or C. two clinical criteria. What are they? Ascites is one, another is a hepatic encephalopathy. And the laboratory parameters are albumin, bilirubin, modified bilirubin, and prothrombin time, and the INR. So if there is no encephalopathy, there is childpox, it is scored as none, 1. If there is grade 1 and 2 encephalopathy, it is graded as 2. Grade 3 and 4 encephalopathy, it is graded as 3. If there is ascites, it's none. If it is mild and controlled by diuresis, it is 2. If there is moderate and refractory ascites, the score is 3. If the albumin level is more than 3.5, it is 1. In between 2.5 to 3.5, it is 2. If it is less than 2.8, it is 3. If the bilirubin is less than 2 milligram per deciliters, it is 1 point. If it is between 2 and 3, it is 2 point. It is more than 3, it is 3 point. Modified total bilirubin, if it is less than 4, it is 1 point. If it is between 4 to 7, 2 point, and more than 7, 3 point. Prothrombin time, if it is less than 4, INR less than 1.7, 1 point. If it is in between 4 to 6 and 1.7 to 2.3, it is 2 point. And if the INR is P time is more than 6 and INR is more than 2.3, it is scored as 3. So child park class A, if the score is in between 5 to 6, then it is considered as child park A. It is very important. And child park B 5 to 7, child park C is more than 9. So ART in the liver disease again is very important. You should know that abacavir is contraindicated in child park B and C. So child park score is very important for the assessment of the chronic liver disease. Abacavir is contraindicated in child park B and C, and used in child park A with less dose. In our national program, it is available around 300 milligram tablet or 60 milligram tablet. So, and if it is child park A, abacavir dose is 200 milligram BD. NNRTI is that is both nevirapine and efavirenz. We are not using these tablets nowadays. It is contraindicated in child park B and C. ATVR. ATVR is not recommended in hepatic environment. Unboosted ATV can be used in child park B 300 milligram OD. And LPVR can be used. It is very important. Sometimes we can see that in our sachet that there is significant chronic liver disease, child park B or C in child park A and B with dolutegravir. Then we can use dolutegravir child park A and B, but it is not recommended. STI is not recommended in child park C. LPVR can be used with caution during liver impairment, and darunavir, ritonavir also you can use mild to moderate liver disease, but should be avoided in severe liver damage. So all hepatitis B, HIV co-infected subjects are candidate for hepatitis B treatment regardless of their hepatitis B E antigen status, DNA, ALT, APRI score, presence of absence of cirrhosis or not, and age. So like HIV single infection, HIV hepatitis B co-infection, all patients should get treatment from our ART center, from our national program. So, what are the drugs available for the treatment of hepatitis B infection? And we should know their potency level against hepatitis B virus infection. There are several drugs. Pegylated interferon. Pegylated interferon is moderately potent against hepatitis B and moderately active against HIV also. We all know that tenofovir disoproxil fumarate has high potency against hepatitis B, simultaneously high level of potency against HIV also. And TAF, that is the tenofovir alafenamide, similarly, highly potent against hepatitis B and also HIV. Entecavir, highly potent against hepatitis B but weak potency against HIV. We are not considering as a antiretroviral drug, entecavir. Emtricitabine, moderate potency against hepatitis B, highly potent against HIV. Lamivudine, moderate to highly potent against hepatitis B and highly potent against hepatitis HIV. And adefovir, very weak drug against hepatitis B. So we must know the potency of these drugs. So what are the drugs? They are very potent, both the TDF and TAF, and moderate or potent lamivudine. Lamivudine is also highly potent. Both drugs are active both against HIV and hepatitis B. And whenever you treat the both co-infected patient, you always treat the hepatitis B with at least 2 protein drug. So when to start ART? According to WHO and NACO, treat all. That is, all patients diagnosed with HIV should be initiated on ART regardless of their CD4 count or WHO staging or age group or population subgroup. Choice of so HIV, like HIV, co-infected patient, all should be treated. I have already mentioned. And choice of regimen. We know that both the 3TC and TDF are active against both infection. So these two drugs should be present along with dolutegravir. So national policy is treat HIV with TLD, and here we can see that both tenofovir and lamivudine are active against hepatitis B also. So beautifully we can manage with this 3 drug combination, we can manage both the infection. So preferred regimen is always TDF, 3TC and DTG. Alternative regimen where there is renal toxicity. TDF we cannot use. Then abacavir should be replaced with in place of tenofovir. But as abacavir has no antiviral hepatitis B activity, so add entecavir according to the NVHCP, National Hepatitis Control Program. And the second line regimen, 3TC should be continued as the part of second line ART regimen following initial ART failure. Even if it is used as the first line regimen, we all know that NRTI backbone should be kept whenever you change the regimen either due to failure. So 3TC based backbone should be there, and which is active both against HIV and hepatitis B. And hepatitis B drug resistance if there, ideally 3TC should be used either with TDF or not at all, because hepatitis B resistant to 3TC develop very quickly. 50% patient develop resistance within 2 years, 90% develop resistance within 4 years if 3TC the only active drug used in the anti-hepatitis B drug in the ART regimen. So whenever we treat the hepatitis B and HIV co-infection, dual drug against hepatitis B should be there. And if we have to change the drug in case of renal toxicity or bone toxicity, TDF you cannot use, then you can, in case of bone toxicity, you can use TAF also, which is highly potent against hepatitis B infection. If you cannot infection both the, if you use both the TAF or TDF, then you should add entecavir in addition to abacavir, because abacavir have no anti-hepatitis B property. Now, flare is very important. I have already mentioned flare means there may be jaundice, there may be transaminitis during the course of treatment. There, after beginning of a antiretroviral drug, there may be flare of hepatitis as a manifestation of iris, or after discontinuation of drugs, there may be flare of hepatitis. There may be flare of hepatitis due to drug toxicity or drug resistance also. And among the potency, considering the potency of emtricitabine and lamivudine, the rate of suppression of hepatitis B virus and the safety profile and the resistance pattern of emtricitabine are like those with lamivudine. So, and if emtricitabine is not provided in the national ART program. So, whenever the TDF is substituted with AZT, treating physician shall recognize the fact that the lamivudine is the only active hepatitis B drug in the ART regimen. So another drug should be added. The NBPDCP is recommending entecavir to add to this weaker regimen. And hepatic flare typically present as an unexpected rise of ALT and AST level and symptoms of clinical hepatitis. I have mentioned within 6 to 12 weeks of commencing ART, if it is happened, that it may be a sign of iris or maybe drug toxicity, or there may be signs of drug intolerance or drug non-adherence or maybe resistance. So what do we do? What we should do to prevent the hepatitis B acquisition? We can either take the pro- procedures, that universal precautionary measures to prevent the acquisition of hepatitis B among the HIV infected people, and also vaccination is recommended. So all PHIV who are estimated as negative for surface antigen should be screened for surface antigen initially. If it is negative, then they should be vaccinated. Double dose of vaccine is needed, and 4 dosage should be given. It is very important. 40 microgram IM 012 and at 6 months. 4 dosage. And washing hand thoroughly with soap and water after coming into contact with the blood, body fluid and contaminated surfaces. Practice safe sex by using condom to reduce the risk of hepatitis B infection and other sexually transmitted disease. Avoid sharing needle or any equipment used for injecting drug or piercing or tattooing. All infant born to hepatitis B positive women need to be immunized within 12 hours of birth. 0 dose followed by 1, 2 and 6 months dose. 10 microgram and immunoglobulin 0.5 milliliter IM. Mother should be on ART regimen, both TLD or tenofovir, emtricitabine and dolutegravir based regimen. So these are the measures and the vaccination measures we should take to prevent the acquisition of hepatitis B among HIV infected population. Now, another infection is important which causes the chronic liver disease and follow the same route of transmission along of HIV, that is hepatitis C co-infection. Globally, 50 million people may be chronically infected with hepatitis C, and nearly 290,000 die each year from hepatitis C related disease. So, hepatitis C related disease may be chronic liver disease, mostly cirrhosis and hepatocellular carcinoma. Approximately 2.3 million co-infected patients live worldwide, of which more than half of the population who inject drugs. So, what are the high risk behaviors for acquisition of HCV among HIV? That is injection drug users, men sex with men, and sexual transmission. Around 11 million people inject drug, and 1 in 3 HCV deaths are attributable to injecting drug use. 1 in 8, that is 1.4 million people of these people are living with HIV, while 39.4% have viremic HCV infection. Injecting drug use accounts for approximately 10% of the new HIV infection, and an estimated 23 to 39% of the new HCV infection occur among people who inject drug. So India national seroprevalence of HCV is around 0.32%. Transmission I have already discussed, that is vertical and perinatal transmission, and sexual transmission common in IDU and hemophilic and thalassemic patient also. So natural course of HCV, then I should remember that is 20, roll of 20. That is around among the HCV infected patient who acquire HCV infection, acute infection develop among 15 to 20% patient, and they cure or resolve by themselves without any treatment. Rest of the patient develop chronic liver disease, that is 55 to 85% patient develop chronic liver disease. Among these chronic liver disease, 80 to 90% patients remain stable throughout their life, and 10 to 15% develop cirrhosis of liver. Among those, cirrhosis of liver slowly progressive is around 75%, and rapidly progressive ultimately reach to hepatocellular carcinoma is around 25%. So, what is the impact of HCV infection among HIV? Co-infected patient with HIV adversely affect the course of HCV disease, and co-infected patient, particularly those with advanced immunodeficiency, that is the stage 4 illness and CD4 less than 200 cells per cubic millimeter, have accelerated course of HCV disease. They rapidly progress to cirrhosis of liver or hepatocellular carcinoma. There is chance of increased hepatic fibrosis progression and also cirrhosis of liver, increased rate of liver decompensation, hepatocellular carcinoma, and liver-related mortality also. And there are chances of the anti extrahepatic manifestation of hepatitis C infection. What are the extrahepatic manifestations of hepatitis C? There may be porphyria cutanea tarda, lichen planus, mixed cryoglobulinemia, psychosis, lymphoma, and all other few of the extrahepatic manifestations of hepatitis C. You can also see among the HIV infected people. There is increased prevalence of the diabetes mellitus is seen among the HCV infected people with along with HIV. There is increased incidence of hepatotoxicity or ART also. These I have already discussed, that these are the few extrahepatic manifestations of hepatitis C. So screening for hepatitis C is important. So all the patient having HIV should be screened for both hepatitis B and C virus. By third generation validated ELISA. So those patients who are positive for HCV, anti-HCV positive, and must do the HCV RNA. HCV RNA core antigen P22 test, that is the PCR ELISA-based antigen detection test, has more sensitivity to 1000 international per milliliter copies of HCV RNA. False negative test they may happen during the window period or blunted immune response. So all those patients having anti-hepatitis C positive should be tested for HCV RNA. And simultaneously, I have already discussed that those history and clinical examination are applicable for hepatitis B infection, are also applicable for hepatitis C infection. So search for signs of hepatic decompensation, that is the liver failure, jaundice, and signs of portal hypertension, cirrhosis, any bleeding manifestations, and also ascites or complication, ascites, encephalopathy, on all that. And laboratory investigations, you always do the LFT prothrombin time and complete hemogram. And similarly, radiological investigation, ultrasonography, endoscopy, and alpha fetoprotein, or 6 months interruption of alpha fetoprotein should always be there. And assessment of liver fibrosis either by the APRI score or FIB score or fibroscan of the liver. All the tests applicable for hepatitis B are also applicable for hepatitis C infection, and hepatitis C RNA quantitative assay and genotyping if possible. In national program, genotyping is not done. So what are the drugs available to treat hepatitis C infection? Pegylated interferon 2 alpha 2 beta and ribavirin, and the directly acting antivirals are there. Pegylated interferon may be 2 alpha 2A or 2B. Alpha 2A dose is 180 microgram, 2B dose is 1.45 microgram per kg body weight. It can be given subcutaneously once a week for 48 weeks. Monitoring CBC and thyroid function test should be done, and common side effects are flu-like symptoms, and as the pegylated interferon is given, so fatigue, mood disturbance, cytopenia, autoimmune disorders, TB should be assessed and discarded, excluded before giving the interferon based therapy. And contraindication, that is autoimmune disease, uncontrolled psychiatric illness, seizure disorder, decompensated cirrhosis, and pregnancy, you can treat the ACV with pegylated interferon. So now oral drugs are available, either directly acting antivirals along with ribavirin or without ribavirin. Ribavirin, this is the guanosine analog drug and nucleoside inhibitor. It is active against hepatitis C. It is not used alone, and it is always used along with the other DAA in the decompensated cirrhosis. Direct antiviral activity increase the mutation frequency of the ACV genome. Dose of co-infection is 800 milligram twice a day for 48 weeks. And GI side effect, alopecia, pruritus, pharyngitis, insomnia are there. And directly acting antivirals, we all know that the three classes are available. NS3, that is non-structural protein 3,4A protease inhibitors, and 5A and 5B polymerase inhibitor. Among the 3,4A 3,4A protease inhibitor, they are all Previr. That is Telaprevir, Boreprevir, Glecraprevir, Paritaprevir, Simaprevir. All these drugs end with Previr. 5 NS5A, that is that they end with Tazvir, Daclatasvir, Ledipasvir, Velpatasvir, and 5B nucleoside polymerase inhibitor soposbuvir, and non-nucleoside polymerase inhibitor is dasapruvir. Dasapruvir has low potency compared to sopobuvir, and daclatasvir has high potency, and all the 3,4A inhibitor are also high potency. Now we should look for the genotypic specificity. We always recommend the pan-genotypic drug, that is soposbuvir or daclatasvir, or pan-genotypic activity, that is the Glecraprevir, Paritaprevir. Mostly these previrs are also pan-genotypic. And high genetic barrier only soposbuvir, all other have low genetic barrier, that is they develop resistance quickly. Drug-drug interaction, previrs have high drug-drug interaction compared to others. And the side effects, they are very minimal side effects along with soposbuvir, daclatasvir or velpatasvir. Sometimes rashes, anemia, and bilirubin may develop with Previrs. So daclatasvir available 60 milligram tablet, and if you use daclatasvir with atazanavir, ritonavir, dose should be reduced to 30 milligram, and if you use it with the efavirenz, dose should be 90 milligram. It is contraindicated with rifampin, phenytoin, carbamazepine, that is anticonvulsant, and St. John's wort. Resistance developed due to 5A protein polymorphism in the 5A protein M28, M30, M28, A30, L31, and Y93. Soposbuvir, velpatasvir have the unique pan-genotypic activity and they are co-formulated, high genetic barrier. They are available in the single pill 400 milligram soposbuvir along with 100 milligram velpatasvir. No dose adjustment is needed in CKD and hepatic decompensation, and side effects are very well tolerated, minimal side effect, drug-drug interaction. The substrate of PGP avoided with rifampin group, and also anticonvulsant carbamazepine, phenytoin, phenobarbital, oxacarbamazepine, or tipranavir, ritonavir. Avoid with amiodarone because it produces extreme bradycardia. An increased gastric pH hinders the absorption of the Velpatasvir. Suppose movie Velpatasvir should always taken with food before 4 hours of omeprazole or equivalent. And resistance develop with Y93NA-H mutation. So how will you manage or approach the co-infected patient with HCV? So people confirmed with chronic HCV infection always assess the chronicity of liver disease by routine laboratory test. First of all, confirm the diagnosis of HCV infection by both doing antibody and RNA. If RNA are positive, then it is considered as HCV, chronic HCV infection, or maybe acute in dialysis, post-dialysis patient, but you should also treat those. And then undertake the baseline investigation along with evaluation of the fibrosis of the liver. If the patient does not have cirrhosis, then always treat the patient with supposed daclatasvir for 12 weeks. Do RN-SVR after 3 months of completion of treatment with supposed daclatasvir for 12 weeks treatment, 12 weeks treatment free interval, then do the ACV RNA. If it is not detected, then the treatment is completed and considered as cured. And if the patient has cirrhosis, then decompensated child-pug A criteria, treat with sofosbuvir combination for 12 weeks, then again assess and again do the hepatitis C RNA after 12 weeks of completion of treatment. If the ACV is not detected, then considered as cured. ACV is detected, then refer to the higher center. And for prolonged therapy, that is sofosbuvir 24 weeks for treatment should be reconsidered for to cure the ACV infection. So the decision to start ART among people co-infected with ACV should follow the same principle as for HIV monoinfection. Tenofovir, lamivudine and dolutegravir is single pill FDC for adult and adolescent recommended. So recommendation of hepatitis C under NVP-DCP, I have mentioned that a patient who have not developed cirrhosis, that is uncomplicated, sofodacla 12 weeks. If cirrhosis compensated, then sofosbuvir combination 12 weeks. If decompensated, then sofosbuvir 12 weeks along with ribavirin, or sofosbuvir ribavirin intolerant patient, then it should be continued for 24 weeks. So these are the drug-drug interaction we always look for. And monitoring of therapy is important. Regular monitoring of the liver and the renal parameters are needed when using the directly acting antivirals and antiretrovirals drug together. HIV, HCV co-infected patients on DAA may have the reactivation of the hepatitis B patient. B infection should always be monitored. Sometimes triple infection may be there, especially among the dialysis, thalassemia, and the hemodialysis patient, thalassemic and hemophilic patient. Additional monitoring for the liver function test is recommended in people with cirrhosis of liver, including albumin, bilirubin, and the coagulation test. People with evidence of neutropenia, thrombocytopenia, and anemia always require monitoring every 1 to 2 weeks. No effective vaccination like the hepatitis B vaccine, where the effective vaccination is there. No effective vaccination is present for a CV infection. And PMTCT protocol, a prevention of ACV infection among IDU, oral substitution therapy, NACP is there, prevent and strict maintenance of disposal of needle, syringe, and the sharps at the healthcare setting should be done. So key point to be remembered that all PLHIV should be screened for both hepatitis B and C infection. PLHIV screened negative for hepatitis B should be linked for vaccination. Referral of hepatitis B and C positive persons to the nearest treatment center on MTC for the hepatitis B viral load more testing should be there. Hepatitis B infection should be ruled out prior to HCV DNA. Otherwise, there may be flaring of the hepatitis B infection during treatment of HCV among the HIV infected people. And post exposure prophylaxis is very important for HBV PMTCT. So if you have any question, you can ask me.
थैंक यू सो मच मैम। किसी के कुछ सवाल है पूछ सकते हैं।
So thank you.
If anyone has a question, please unmute their mic.
Thank you so much, ma'am. Any questions from the
Thank you.
participants? Please feel to unmute your mic or you can put your questions in the chat box. Ma'am, I don't think there are any questions. Thank you so much for
Okay, thank you,
facilitating this
Siddharth. Thank
important
you, Kiran.
session. Any questions? Thank you, ma'am. Thank you to all
Thank
the
you all. Thank you.
participants. We'll conclude this session now.